So welcome, everybody. I would absolutely say that first off, kudos to joining tonight. I think tonight's course is truly going to be, in my world, thinking this is the future of where dentistry is going. I want you to think of like dentistry's blood test, where you go to a physician and get blood tests routinely. And why do we do that? We do that. Let me just make sure we can get this going. We go to get blood tests to predict risk. And tonight, what Stephen and I want to do is show you a whole different way of thinking. And it's a tough course because it's only 45 minutes. But when we're talking about risk factors for caries and periodontal disease, and they can be whether low, medium, or high, how do these risk factors then tie into the diagnostic approaches that we currently use, and then kind of fill in the puzzle pieces on how we ultimately can treat our patients? It's my firm belief that we are heading into an era that we will stop using traditional diagnostics and move into an era that will supplement traditional diagnostics. And when you look at this picture, you realize that traditional dentistry has been the same for over 70 years. You get X-rays, you get explorers, and perioprobes. Now, you all can say that's wonderful, but it's really not wonderful. And the context of this course tonight is we have to move away from guessing what disease status our patients are in and be far more predictive. And I start off with these two statements. The current diagnostics for caries is mainly related to a caries reactive approach. We see caries, whether with an explorer or an X-ray, and we react. The same can be with a perioprobe. We take an X-ray, we have a perioprobe, and we react. And I think we have to start thinking in a whole different mindset. Let me start off by saying that if you see bleeding on probing routinely, you would think it's a predictive, uh, it's predictive of future tissue loss. And the answer is bleeding on probing is only predictive of 30% of the cases. Negative bleeding on probing has a specificity of 98%, meaning it's got a negative predictive value. So it's very accurate when there's no bleeding, but when there's bleeding, it's only 30% predictive. So look at the wide range of bleeding and not bleeding, and you realize we're guessing. So how important would it be to finally really have diagnostics that could be predictive of future oral disease? Knowing which patients you could go into early remineralization treatments like a periodontal repair if you knew that they were genetically at risk. Or imagine knowing years before periodontal disease even showed itself, you could predict that a patient would be coming into a periodontal disease status, and you could have preventive measures with a long onset, way before the disease truly started. That's really what we're talking about. Genetic and saliva testing. Imagine how valuable their insights would be to evaluating patient-specific profiles for both caries and periodontal disease. And I think Stephen and I are going to enlighten you tonight because I think we're all asleep at the wheel when we're talking current diagnostics. And really, the goal is for you to kind of just continue to think through this evening together on how you diagnose your patients. During recall appointments, you could do saliva testing, and that's not what we're really going to get into tonight. But those saliva tests could be more indicative of ongoing risk factors such that honestly, they're just adding more diagnostics to your practice and how to treat a patient in a predictive manner versus always a reactive manner. Tonight, we're going to talk about the oral risk test. It's a one-time only predictive test for your patient's risk profiles for caries and periodontal disease. And Stephen will really dive deeper into the test. But imagine if you knew a patient is walking into your office and they have certain comorbidities, which we're going to get into, how valuable would that be given their medical history and their dental history to know if they're higher at risk or not higher at risk for caries and periodontal disease? And to me, knowing ahead of time that my patients would be prone to developing periodontal disease, man, that would be so advantageous in literally setting up different preventative protocols, which we'll talk about briefly tonight. And if they're low risk, then maybe every 6 months is fine. Maybe every 6 months and flossing and brushing is fine. But is that fine for your high-risk patients? So here's your first true or false question. Genetics has a substantial role in caries risk factors. I would bet you before you came on tonight, you wouldn't even have thought about this. But the truth is, this is absolutely true. I'll go to the next true or false. Genetics has a substantial role in periodontal risk factors. And again, this is absolutely true. So here we are knowing through decades and decades of research, both these answers are true, yet we have not yet implemented genetic testing in our practices. The research really dates back almost 100 years. So starting in the 30s and moving it forward, there was a clear pathway understanding genetics involvement for patients at caries risk. And when you look at just a sample of all the research that has been going on, it has enlightened us to understand so much about the caries process. So I want to talk about the Vipahome study from Sweden. And this study was done really almost 70 years ago. And what they did is they took 436 subjects, split them apart, and one was obviously a control group and one wasn't. And they wanted to determine diet, frequency of sugar intake, and dental caries. This is what we've been all taught in dental school. So what they did was they administered sugar during meals and in a solution form, or they administered it in a sticky form between meals. And the study positively showed that sticky sweets between meals rather than during meals significantly increased the dental rate, the incidence rate of dental caries. And it showed a major involvement of carbohydrates in the development of caries. You all know that. The study missed a lot. And this is quiz questions for all of you. So this is why this is so important. The studies show that despite the sugar consumption of various subjects that consumed a lot of sugar, they did not develop caries. Why? It also showed that patients did develop carious lesions that were not consuming high amounts of sugar. So when you look at this, you would call a patient low risk. A low risk patient, they're consuming sugar and they're not getting caries. And yet a high risk patient could be someone who's not consuming a lot of sugar and they're developing caries. So there were a lot of question marks posed even after this study. Genetics can affect up to 65% of how susceptible someone is to dental caries. So let me show you what some of these genetic factors are. For example, the tooth shape. If teeth are crowded, and this is all genetic, they come in crowded, they're more caries prone, and home care even becomes that much more important based on the misalignment of teeth. Enamel. The composition of enamel itself can be more vulnerable based on the genetic pattern of that patient. The big one is salivary factors. And I don't know if you all know this, but composition, flow rate, pH, and buffering capacity are all genetic. And there are now saliva tests that can evaluate this and do it within basically 15 minutes. But tonight we're going to talk about a genetic test that can tell you if a patient is high caries risk genetically. The immune response, fighting off the infection process, is all genetically related. And taste. Taste is genetically related. So if a patient has an altered taste response or an altered taste perception, this could allow them or have them engage in more sugar consumption. All of these things are genetically related. So we've been taught caries, and this is out of a textbook, obviously is going to occur on a host tooth. We've been always taught it's related to the substrate, carbos, strep mutans as the primary villain, and an amount of time. That's how we were taught caries. But genetics absolutely involves all of the things that I've just described. So it isn't a simple caries. It's based on carbos, strep mutans, or lactobacilla, and how much time they get to munch. There's far more to this, and that's the genetic component. The periodontal dilemma, all immune responses are not created equal. So let's talk about the research in perio. For decades, research has shown that genetics has not a casual, but a causal relationship with periodontal disease. In fact, 50% of periodontitis susceptibility is credited to hereditary or genetic factors, and yet we're not testing our patients. That's about that. 50%. So the way I best describe this is from Kornman's study. This is the classic study in 1997 regarding periodontal disease. You have a microbial challenge in a pocket. The microbes release antigens and lipopolysaccharides. The host, in response to the antigens and lipopolysaccharides, releases antibodies and polymorphonucleosides. If everything's in equilibrium and the body's defending itself well, we have no progression of periodontal disease. But what we have learned to understand is that there are environmental and acquired risk factors, which are medical risk factors, along with environmental risk factors that can alter the host immune response, and genetic risk factors. And if they alter the host immune response in a negative way, the host responds by releasing cytokines, prostanoids, and MMPs, creating bone loss and tissue loss. That's where we're at. So it's not just how the human body responds, it's how the environment gets involved, how medical comorbidities get involved, and genetic risk factors. This is the complication or the complexity of periodontal disease. So let's talk about diabetes as a risk factor. There are almost 40 million Americans who are diabetic in the United States. This will alter the host response. Someone who has diabetes is almost 3 times more likely to develop periodontal disease. There are almost 100 million Americans who have type 2 diabetes. So again, you're going to affect the host immune response. And these patients are all coming to your offices. Obesity, per the Offenbacher study, there are 100 million Americans who are termed obese. And this has also been correlated to periodontal disease. So when you have patients who come in and fill out their medical history, this study came from Journal of Oral Microbiology about comorbidities. We're talking about cardiovascular disease, diabetes, type 1 and type 2, rheumatoid arthritis, osteoporosis, Parkinson's, Alzheimer's, psoriasis, and respiratory infections. These are comorbidities related to periodontal disease. So your medical history is indicative of an increased risk factor alone just from the medical history. When you look at the medical history in red, these are risk factors for sleep apnea, comorbidities. When you look at environmental risk factors, now add smoking. Another 28 million smokers, about 20 million marijuana users, it's probably double. Add e-cigarettes, cigars, smokeless tobacco, pipes. You're talking between just diabetics and smokers, forget all the other comorbidities, but at least 175 to 200 million Americans. So comorbidities and risk factors are already presenting every day in your office. So now you have environmental risk factors, you have health risk factors, and now Stephen's going to get into understanding genetic risk factors. Stephen, I'll let you start and introduce yourself.
Good evening, everybody. So my name is Dr. Stephen Moore. My background is in medical genetics, and so I work with the oral risk group at AI Genetics. So I'm going to be talking to you this evening about the test and a little bit about how the results will be put out into reports for once the test kits should come back with the results. So looking at the kit itself, this is what you would have. It's a very basic kit. There's some instructions explaining, walking through how to collect the sample. There's a tube in there with a swab you can see pointing out on the left side there. So this would be simply put into the mouth, and you take the cheek and the gums, you swab it 10 times 10 seconds, and it would collect enough sample. You just reverse that, put it into the solution, close it up, and it's ready to mail off into our genetics labs. So relatively straightforward, doesn't take a long time. All right, so here's a little video, just kind of walking through the patient's experience as they open the kit and walk through it. All right. So there, like it showed very briefly, there is a portal. There's an online portal that they would get access to. And I think Suzanne's going to talk a little bit more about that later. So the oral risk kit, which is a test for both periodontal disease and dental caries. So this looks at the individual's risk of developing these two common conditions. So the risk is a genetic risk. It's not associated with the bacteria in their mouth. It's based on the genetics of their body, if you will, on all the different components that Dr. Graham walked through just recently. So for the test, here's kind of an example of plotting an individual's relative risk for developing, in this case, for example, a periodontal disease, but also dental caries shown. There's one test for life because your DNA in your body doesn't really change unless it's, bad things happen. But otherwise, this is pretty much what you're set with. And so you only need one test throughout your entire life. The results will be presented in one of three categories, and one for the periodontal disease risk factor, and then one for the cavities. And you can see here it's organized relatively straightforward, showing either a low risk, an intermediate risk, or a high risk, and the arrow indicating specifically the individual's test scores. So in developing the panel, what we wanted to do is we really selected what brought us actually to bringing this panel into development was what Dr. Graham just talked about. So all the market research that we looked at, we wanted to look at some issues that had clear problems and preventable approaches that could be done. And we scanned over the genetic research. So we looked at high-level evidence and peer-reviewed research called genome-wide association studies. And we found that in dental caries and periodontal disease, these are two well-characterized disorders or diseases, if you will, that can have a high genetic influence and has a preventable approach. So we thought this was a great opportunity to develop a panel for this market. So the next one was we wanted to look at the genetic markers involved that had a strong correlation with the outcomes or the risks, if you will. And these are all markers that are ranked and weighted according to the evidence and according to how many times it came up in the literature. And this brought together 25 markers for periodontal disease and 35 markers for dental caries. Unique to AI genetics in this scenario is that we specifically targeted markers that were in the literature, well associated through studies to be involved with these issues, rather than starting with a panel of, say, 400,000 markers and hoping one of the markers or two of the markers has some association. So the development of our panel is very, very specific and a differentiator in the market of only looking at the top markers and associated risks for these two diseases and caries. So what we've developed is used already in the clinic in developing, looking at cancer risks. So this is looking at what's called a polygenetic risk score. We're the first ones to try this and use this and implement it into the dental clinics. And so it's kind of a, a great opportunity to bring new science into a different field, moving from oncology into the dental practice. And what we can find is we use a, like a probability risk score. And then what that does is it compares the genetic risk factors of the patient that we find in the panel with the overall high risk genes that we know have been reported in the literature. And so what this does is it gives a baseline score and compares it to the normal population, giving the risk assessment for that patient. So, like I said, the analysis of the genetic data. So once the swab's taken, it's put into the kit and it's shipped off. It's sent off to a genomic center at the Mount Sinai Hospital, and the DNA is extracted. And the number one thing here is to make sure there's enough sample in available. So that's the number one quality check. And then you go on to various different validation markers to make sure that there's the sample is appropriate. And then we look into getting the results, and that's interpreted by certified geneticists in the lab. Raw data is provided, and once that raw data is provided, we're putting it into the polygenic risk scoring system, and the report is generated for the clinic and patient. Here's an example of what the actual dental report will be. We tried to make it user-friendly. You'll see two different pages. This page here is designed more for the patient, and it's explaining their low risk, high risk, and where they fit into that. It gives a little bit of synopsis at the bottom there, explaining what the polygenic risk score is, how it's distributed, and giving them a little bit of understanding of what that high risk or low risk actually means to them. The second page gives a lot more detailed information. So this was designed in collaboration with the director of a molecular diagnostics lab, giving all the necessary information into the diseases as well as what would be needed to explain the test itself. Also, the next steps is given based on your risk score or the patient's risk score is to help define a plan to better suited for their individual assessment. So this is like I was saying, the test methodology is always shown out there, so it can be described. We do quite clearly indicate our test limitations, and because it's a predictive test, it's not a diagnostic test. And there's various references that we've used that align with the polygenic risk score and the various different methodologies we've used for developing the test and validating it. All right. So this is an example of the the portal. And with that, I will pass it on to Suzanne to carry on.
Thank you, Dr. Moore. So my name is Suzanne, and I coordinate operations for AI genetics, and specifically for the oral risk test. And I'm just going to walk you through the portal. We have spent a lot of time, as Dr. Moore shared, in research for our actual product, our medical product. But we also spent a lot of time in research for our product, for how it will implement itself into your clinics. So this is the portal. And you have the ability to sign up your clinic as its own profile, so that you can then register patients under your profile. So when you are registering a patient, very quick, the number one or two things that we got back in feedback from our research is, one, it has to be simple, and it also has to be fast. So you will fill in basic information for the patient. And then you can then go to your profile and add them. And with the patient present, you can consent for them. And then you'll put in their barcode. So very important, the barcode entered matches back with the barcode that we have in our system. And that is all that you have to do on the clinic side. Your patient will then be given an email that they can log into their own profile, and they can fill in additional information. You will now have access to see all of the patients that you have signed up under your profile, and they will also have access to their results as well.
So I'll take it over. Thank you, both of you. And I thought I would walk through two patients. And this will be brief, but I think you'll understand the importance of genetic testing. Let's talk caries risk first. So Elliot came to our office last year, and he had a non-contributory medical history, but he had high caries risk in that he had 10 restorations already done, which is a lot on a 28-year-old. So we'd call him high caries risk. In his dental questionnaire, he said he did not eat a lot of sugar. He wasn't a sweet guy. He was a sweet guy, but not a sweets guy. Didn't drink a lot of soda, brushed twice a day, didn't floss enough. He admitted that, and it had been 18 months since his last dental visit. You can see all the new lesions, and I'll get into his x-rays in a few seconds. Here's Elliot, and you can see the previous restorations, and let's dive a little deeper with some 2D AI from Pearl. Pearl, when you use the platform, and we've been using it now 4 years, even when it was in beta, every one of these x-rays in his bite wing shows a pink dot, and a pink dot means there's caries noted in that on that patient. We'll dive a little deeper. So we know now he's got caries identified by Pearl. So this is what you normally look at. This is what Pearl would identify. This is what we call tooth parts, explaining to the patient. And then you can actually take your mouse and zoom in over one of the carious lesions, and it will tell you how much it has progressed into dentin. When you're trying to explain enamel or enamel caries or dentin caries, this is a really useful tool. The lighter pink are incipient caries, and the deeper pink are caries that are now into dentin D1 and D2. This is all Elliot. So when you look at the E1 and E2 lesions here, these are all E1 and E2. What is the likelihood of these cavitating into D1 and D2 lesions? What is the extent of his risk? And I think this is a clearly defining patient of risk factors. And I would go, is brushing and flossing the only answer you have? So he's a power brusher and doesn't floss enough. And yet today, if we evaluate a patient's risk, we have all of these solutions. And whether it's a varnish, crystal care, Curidon, SDF, or Icon, these are all solutions for high-risk patients if we feel they are necessary. So the first premise I'm going to say is when we have a patient in the chair, if you tell them something, they're going to forget it. Premise number two is if you show them, they'll remember. And premise number three is involve me and I'll understand. So I'm going to take this patient and involve them both with Pearl, but then I'm also going to do an oral risk genetic test. So now we've taken 2D x-rays, which at best are 60% diagnostic interproximally, and I said at best 60%, using 2D AI to enhance our diagnostic ability to a greater degree to understand his risk factors. But would you not want to genetically test a high caries risk patient to establish a baseline of risk? And then I would go back to you and say, if you don't, do you really think flossing and brushing is enough for everyone? And you all clearly know it's not. You can have patients who brush and floss and they still develop caries. And that's the high risk nature of those patients. So let's say we tested Elliot and he came back high risk for caries. Would you then be even more insistent in recommending varnish treatments, flossing, fluoride rinses, high dose fluoride toothpaste, potentially as your initial approach? But is that enough in a high risk genetic patient? If he's low risk, that might be enough. Would you be more prone to thinking he's high risk genetically? You've got the test, you've gone over it. Would Curodont repair, with its huge success rates of 70% remineralization and 93% if you're adding a ongoing MI paste routine after you do the repair, do you think that would be an additive benefit to a high-risk patient? Would you add their recall appointments to every 3 or 4 months? Would you add more frequent diagnostics like transillumination or fluorescence to evaluate your 2D x-rays? Would you be more inclined to do ongoing periodic salivary testing to evaluate his pH, his buffering capacity, all of those things that come out with saliva testing? Or would you also be more inclined then to maybe get him a power flosser, such as Slate? Or would you put him on a variety of maybe different probiotics? Or would you give him remineralization trays or a plaque inhibiting toothpaste like Live Fresh? I know a lot of these are new topics to all of you, but this is how rapidly dentistry is changing. And then think about it this way. If a patient knows his or her risk profile is now high, will that patient be more compliant to your recommendations and come in more frequently to avoid you drilling in this case? This is where genetic testing has a huge play. Perio risk or periodontal risk. This was a patient who came in over 18 years ago, and she came in with already previous treatments of implants and periodontal care. She came in with a history of type 2 diabetes and a long-term struggle with her A1C. She had a long struggle with her weight. She then developed cardiac issues in the last 10 years while she was under our care, along with high blood pressure. So when you look at comorbidities, you're going to understand why I think my office failed this patient. She was on a 4-month recall system with perio maintenance and lasers. She was diagnosed with sleep apnea and wore a CPAP. She flosses every day. She's a power brusher. She uses a water flosser. She was non-compliant with perio protect trays that we gave her. But for the most part, she's flossing, she's power brushing, she's using a water flosser. And you would think we would get her perio under control. So she comes in, and this is now year 18. This was last year. She had 24 bleeding pockets. So she's a diabetic, type 2, cardiac issues, all other comorbidities, and 24 bleeding pockets. Do we have a handle on her periodontal health? And the answer is we don't. Going back to Pearl, identifying calculus subgingivally, caries, and radiolucencies. We go into second opinion in Pearl, and if you look at the green dot is calculus. What we found was in every quadrant, she had subgingival calculus, let alone progression of periodontal issues, peri-implantitis around her implants, which comes hand in hand with uncontrolled perio. We did not have a handle on her perio, and she's a diabetic. Let's take a look at this one X-ray. Just so you understand, your eyes see 30 shades of gray. 2D AI sees between 5 and 800 shades of gray. So we are very poor in identifying early subgingival calculus. AI can absolutely better our diagnostics. So here it's identified on the lower right tooth, and it's identified on the upper right canine. Periodontal bone loss. Yeah, it would be better to have a better X-ray for sure on number 30. But when you're evaluating periodontal bone loss, dentist accuracy at reading this is still under 45%. Well, I shouldn't say that. Periapical pathology is 45%. It's amazing what we miss in periapical pathology. And reading bone loss, we are still under 60%. So our numbers are truly flawed with 2D AI. With 2D AI, and in this case now where it starts adding, is it starts measuring from the CEJ to the crest of the bone. White would be a normal reading, yellow would be mild bone loss, orange would be more substantial bone loss. So what we can do is we can actually, with 2D AI today, take two comparative X-rays. Yes, the angles are somewhat off. I mean, this is the imperfect science of taking traditional X-rays. But if you start looking and comparing between 2 years, her bone loss on the right was getting worse from white to orange. Here it went from yellow to orange, meaning deeper. Here it went from white to yellow. So she's got progressive bone loss, and this is all shown in Pearl. When you take this data to her perio charting, you can start to go, is that really a 3 millimeter pocket when it was really a 5? And you start taking the 2D AI interpreted data, looking at your probings, and oftentimes we have seen that my hygienists are miscalculating or misprobing their numbers. Here we have a defect that was not a 3 millimeter defect. And on the bottom right, was it really just a 5 millimeter defect? And again, is this a small defect? Is it really just a 3 millimeter defect? So now we take 2D AI and start to understand ongoing disease, but we're being reactive. So now you look at the data points. Perio probing, 24 bleeding points, and where normally it's 30% predictive of future disease, if she's high risk, it's going to be far more predictive of whether she's high risk. The fact that she's a diabetic makes her higher risk. Subgingival calculus and continued bone loss was noted on Pearl. So then the question is, how important is it to control her periodontal health? Because we all know if you don't control her periodontal health, it will affect her diabetes. And her diabetes then will affect her periodontal health. It's a two-way, it just goes back and forth between the two. So we know she's high risk for diabetes. We know she's got high blood pressure, cardiovascular disease. We know perio is an episodic disease in itself. and that it gives an altered, and she's giving an altered immune response. So I go back to all of you. Is probing her the best and only, or the only and best diagnostic tool we can offer her? Do you require more information? And the answer is absolutely yes. We need a baseline of information, and then we need follow-ups. This is what we're doing currently. This is what we've been doing for years, and we still faltered on this patient. You may want to do bacterial DNA testing to understand which microbes are in her mouth causing the disease, and then treat those microbes, whether with antibiotics and therapy or whatever therapy you want to use. We may want to use salivary testing to see whether the patient is at greater risk from the salivary testing, which also can evaluate MMPs and PG and other risk factors. And then you could also offer her a one-time only genetic test, like AI genetics, where now you're establishing what are her risk factors. So let's just say we opened up the kit and evaluated her. I'm going to have Stephen then walk us through on one brief slide, what does that evaluation show? Stephen?
All right, thanks, Dr. Graham. So to summarize kind of what we were talking about earlier, so this is the polygenic risk score distribution curve. And the results really are when you take a patient's risk score, it can be compared to known genetic risk factors. That's what we got with the genome-wide association studies pulled from the literature. And we estimate the patient's overall likelihood of developing the disease. So when we look at either 25 or 30, however many risk factors we've analyzed for either one, if the patient carries multiple high-risk genes known through the literature, then their baseline risk will increase significantly. So this potentially multiplies or adds to their clinical risk assessment.
Now you take what Stephen just said, and I'll get to that in 1 second. So these are the codes. And 0423, if you read it, it's a genetic test for susceptibility to diseases through specimen analysis. And it says it is shipped to a genetic testing laboratory versus something done in office. So that is the code you would use. Now, I know what you're all going to ask. Does insurance cover this? And the truth is, in time, they will. But if this is an out-of-pocket expense, and we'll get into pricing when Suzanne closes today, is this an out-of-pocket expense that would be worthwhile for the patient? And that's what you have to best understand and explain that to the patient. And to me, someone in this case who's a diabetic with cardiovascular history, it's enormously important to understand her true risk factors. So let's say Risa came back high risk. Do you refer to a specialist to develop a plan? Is this over your head right now? Are you more determined to offer treatments beyond just traditional scaling and planing? Do you offer lasers, guided biofilm therapy treatments? Do you do bacterial testing? Now that you know she's high risk, would you do bacterial testing as a baseline and then subsequent reevaluation? So you evaluate her bacteria, then you treat her, and then you do post-op bacterial evaluations to see, are those numbers going down? Do you utilize the same with salivary testing, understanding before treatment and post-treatment? I really believe that if she's high risk, you are now going to get into, just like a high caries risk patient, you're going to have to dive into treatments like Perio Protect, perio-specific additional treatments, whether probiotics, power flossers, a powerful anti-plaque toothpaste that lowers gingival bleeding and gingival inflammation, much greater than any traditional toothpaste. How do you eventually determine her recall schedule if she's high risk? And then the question is, does she become more motivated? So you come back, you're sitting her in the chair, and you've got a positive high risk versus a low risk. If she knows she's high risk, that means inherently she's got to do more, and you're going to have to do more to be more preventive. So let's talk about, and we'll finalize with this, couple things. Who would you test? Well, if a patient comes in with a family history of periodontal disease, so you have a 37-year-old patient and her parents both had periodontal disease, and now you know the genetic markings with it, I would test them. If your patient has ongoing periodontal issues and they've already had periodontal treatments, I would test them. If they have a medical history that includes cardiovascular disease and the rest of those that are listed here, I would test them. Because if we failed Risa in our therapy and then she developed cardiovascular disease for her ongoing periodontal disease, that's on us. So these are the ways I would look as who I would be testing in the office. If you have a patient who's obese, they've got really poor managed stress, which is a huge indicator for periodontal disease. If they're a smoker, if they've got dry mouth or a history of high caries risk, I would be testing all of these patients. And then you think about who else to test. So if you're beginning periodontal therapies with a patient with a high-risk profile or a history of periodontal disease, or their parents or sister or brother, I would be testing. I would be testing these before doing surgeries, periodontal surgeries on a patient. Why? How many of you have seen periodontal surgeries fail in year 3, 4, and 5? You've seen this. I've seen Lenop fail. You'd want to know the risk profile to guide them to better prevention. Implants. First off, we shouldn't be placing implants on periodontally involved patients. But if we know they're high-risk perio patients, then you're going to be delivering more preventive appliances and therapies after you deliver your implants to prevent peri-mucositis and peri-implantitis. And you're going to test patients if you're about to undergo very large restorative casework. Why? If they have a history of caries and they come back high risk, again, what are you going to do to maintain a dentition that you've done full mouth rehab on, or 3 bridges, or whatever? Or lastly, how do you manage high-risk patients in a more customized approach? All of these are indications for genetic testing. I'm going to close on how I explain this to a patient. I sit a patient in the chair, they're sitting up, and I go, look, I've looked at your medical history, I've looked at your dental history and your lifestyle. We've shown all of you tonight that lifestyle can absolutely affect caries and periodontal disease, ultimately a patient's oral health. So they could be at higher risk for developing cavities or gum disease. I would then tell them genetics just has a direct role in the onset and the possible way it interacts with both of those diseases, which inherently adds risk to you. Then we just say, look, we have an easy test. We're going to just take a simple swab, and we're going to find out if you're low risk, average risk, or high risk for either disease. And trust me, all of you listening would love to know if you're low risk, high risk, or medium risk. And if they're higher risk, I would tell them, look, we're just going to have to come up with a more customized approach in your care and how we're going to have to develop a more preventable approach long term. And can I answer questions? It's that simple. Because I think compliance becomes a key factor in all of our successes. And when I look at this, I think all too often a hygienist or a dentist, they fail to create the need for a patient. And if they don't create the need, then it won't drive the patient to want to follow their recommendations, whether for therapy or long-term care. This is the need and want. And when I look at the need and want, I truly feel AI genetics, other salivary testing, other things that we'll be rolling out will allow the patient a true understanding of the need, and then this will turn the patients really into understanding why they should want their care and their preventative approaches that you're prescribing. That's the role that I see, and I see this going forward for genetics in dentistry. We're going to take a lot of questions. I know this is new to all of you, but afterwards, Suzanne will talk about how to get the test and everything else, but I'm going to turn this over to questions. So the question is, what bacterial species are tested? This test does not test bacterial species. This test evaluates the genetic susceptibility of someone being at periodontal at risk. When you do specific bacterial testing with additional testing, you'll be testing whether it's a red complex microorganism, an orange complex microorganism, or a green complex, and the different levels. So routinely, bacterial testing will cover around 8 to 10 different species. How much do you charge the patient for testing? Well, Suzanne, why don't we tackle that one first, because that's a good tackle. Why don't you explain pricing?
Okay. So the test kit is $140 to the patient. As Lou has shared with us, there is a billing code that can be used that will help to reduce the cost of that test.
So let's do this, Suzanne, for the people on this tonight. Then I'm going to answer the DNA question about protecting. Let me ask you this, Suzanne. What is the retail cost of a test to a dentist? What is the cost of the test?
$140.
So I would tell everybody out there that in my practice, if I'm paying $140 for the test as a one-time only test, I am probably charging a patient $200 for the test itself. You want to charge $250 or more, that's up to you. But inherently, all you're doing is taking a swab and sending it out. There's no chair time whatsoever. And so, Suzanne, with that being said, it said, how are the patient's DNA info protected? Talk to us about HIPAA compliance with the platform.
Yes, so we have full HIPAA compliance. We also have FDA approval and Health Canada approval. If anybody is interested, they can reach out to me and I can give you all of the documentation if you would like to have the full documentation on our approvals.
Great, thank you. So one of the questions is, and I'll just say, Lou, give us examples of customized treatment beyond what you're doing now. So the way I look at it, let's take Elliot. If Elliot was low risk in caries and low risk in genetic testing, then I would probably go back in and reinforce a traditional flossing, maybe power flossing, power brushing, and maybe an oral rinse, and of course doing fluoride therapies or fluoride varnishes if he's at a lower risk. But if he comes back genetically at a higher risk, I'm going to convince him to invest in a toothpaste like Live Fresh that most of you have not heard of. It's so well studied. And what Live Fresh does is it lowers the plaque by 250% on a tooth. So if I can lower the plaque, that is just one example of something that I would do. If someone is high risk, I'm absolutely going to make them remineralization trays. I'm absolutely going to be instructing them to use an MI paste or a Remin Pro on a once or twice daily regimen because I know they're risk. These are at-risk therapies. If I know someone's at perio at risk, I'm going to see them more often. I'm going to then probably without question put them on Perio Protect. And with Perio Protect, their regimen may not just be once a day for 10 minutes. It may be twice a day for 10 minutes. I may have other recommendations on how I would treat them probiotically and with other ways, again, with a power floss and other things, if I know they're higher risk versus they're just not brushing and flossing enough, or they're just low risk. So I think my feeling is that there are more and more opportunities here. And so if someone's high risk and they have early enamel lesions, I'm absolutely going to do Curodont because I don't feel a fluoride varnish is enough treatment for them. So all these treatments are coming out today that weren't even available 5 years ago with great success. That's how I would alter what I would do for a patient. Conversely, if I see a low risk patient with 1 or 2 lesions and they're low risk, I may not even drill a D1 lesion that could have been there for 5 years because it could be inactive. But if I know they're high risk genetically and I see multiple lesions, I don't feel I'm going to probably watching them. There's also other devices coming out. One is a product called CaviSense. Looks like a little toothpick, and it can read the pH interproximally on a tooth. So if it's below 5.5, you know there's demineralization going on. If the patient's high risk, I am not going to wait. I'm going to do minimally invasive dentistry or reparative dentistry on that patient. Those would be examples. And that's why this is ongoing. This is just identifying a patient at risk. Now, you could say, why don't you, Lou, treat everybody at high risk? Well, why should someone buy a $20 toothpaste if a traditional stannous fluoride is fine for someone lower at risk? So I believe we should tailor our therapies based on risk profiles. Do you use a 10% carbamide peroxide for its anti-karyostatic effects in your patients who are higher caries risk? Well, again, what am I using that 10% carbamide peroxide for? Am I using it in a tray? And if I'm using it in a tray, I usually would use routinely either a remineralizing paste or actually I use PerioProtect's 1.7% hydrogen peroxide, which equates out to like a 7% carbamide peroxide. But it's a good question. But again, you're thinking now the way you should be thinking. Higher risk, do I want to use that 10% formula? Please state the name of the pH toothpick. It's called CaviSense. CaviSense. And as you insert it, you hold it there 10 seconds. As you pull it out, its color is like a blue-purple. If it turns yellow, you have demineralization going on, and it's called CaviSense. Okay. Questions? I'm here for you. I just want you to be thinking this is really to allow you another opportunity. So I'm just going to close on this. I think when you test a patient like Risa and she comes back high risk, the hygienist is on alert, the patient is on alert, and they realize that they truly have to do more than traditional perio maintenance therapies and traditional scaling perio therapies. That's how I would look at it.